Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Jazz Pharmaceuticals, Inc.
Hello, and thank you for joining our webinar today on cardiovascular safety and symptom management of narcolepsy and idiopathic hypersomnia. I am Dr. Barbara Hutchinson, president of Chesapeake Cardiac Care and in Bowie, Maryland, and I am delighted to be with you today. Over the next few minutes while we are together, I want you to recognize that during this our discussion today, there may be products that have not been approved by the U.S. Food and Drug Administration that are off-label uses of approved products that we are talking about today, and that they've been presented in abstract form. So this data should be considered just preliminary data as you hear today. So as we begin our conversation today, let's go back to the beginning. Narcolepsy type 1, where the classic pentad of symptoms usually include excessive daytime sleepiness, cataplexy, which is involuntary loss of muscle tone due to either a positive stimulus or sometimes a negative stimulus. It could be laughter or it could just be anger. Disrupted nighttime sleep, hypnagogic or hypnopompic hallucinations, either as you go into sleep or when you awake, or sleep paralysis. And when we talk about type 2 narcolepsy, the similar symptoms, except there is no cataplexy, but there is still that excessive daytime sleepiness. Looking at the international classification of sleep disorders, narcolepsy type 1 usually involve cataplexy and low levels of orexin A. On the other hand, narcolepsy type 2, there's usually no cataplexy and the orexin levels are usually not low, as in type 1. On the other hand, as we look to idiopathic hypersomnia, this is usually diagnosed using a multi-sleep latency testing that is usually less than 8 minutes, or sometimes a 24-hour polysomnogram where total sleep time is greater than 11 hours. It's very important to exclude the fact that in this, there's usually no cataplexy, and also need to exclude any other sleep disorders or any medical or psychiatric disorders that can cause hypersomnia, or even drugs or other medications. There are some challenges, however, in the diagnosis of idiopathic hypersomnia versus narcolepsy. When we think of idiopathic hypersomnia, it's usually trouble waking up, whereas narcolepsy, there's usually trouble maintaining wakefulness. But as we think of the testing that we usually use in diagnosing these two conditions, when we think of the polysomnogram, very rarely can we measure the maximum total amount of sleep. And when we do the MSLT, we usually measure daytime sleep propensity and not necessarily the ability to wake up. We can often use to assess total or to assess the sleep time. This slide just is here to remind us of the fact that narcolepsy by itself is not without comorbidity. The Bond study that was done by Black and his colleagues, this was a retrospective study covering claims data for approximately 5 years and over 55,000 adults over the age of 18 years. Of these adults, over 9,300 had type 1 or type 2 narcolepsy, and they were matched with controls. This slide clearly demonstrates that narcolepsy is associated with respiratory diseases, musculoskeletal diseases, nervous system, and circulatory diseases. As you look down the list, you can see the array of comorbidities that's associated with narcolepsy. If we look specifically at the risk of narcolepsy and cardiovascular risk, we see that there's an increased prevalence of hypertension, coronary artery disease, congestive heart failure. And there's also an increased stroke risk as well as myocardial infarction risk. Looking next at idiopathic hypersomnia and cardiovascular comorbidities, in a retrospective study that was also done looking at 5 years of US claims data from 2014 to 2019. And here we looked at just under 5,000 newly diagnosed patients with idiopathic hypersomnia. And they were again age matched with controls. And here you can see in idiopathic hypersomnia, there's increased prevalence of hypertension as well as cardiovascular disease. Of note here, coronary revascularization and myocardial infarction were not very significant. There was also significance across major adverse cardio events, arrhythmias, edema, and congestive heart failure. As we look to the future, when we look across or look at cardiovascular disease across adults in the US, we can see that the prevalence of hypertension is going to increase between 2020 and 2050, going from just about 51% to 61%, increasing by 10%. On the other hand, we may notice that health behaviors such as physical activity, smoking, and dietary changes, these are all projected to improve, whereas inadequate sleep is projected to worsen. So by 2050, more and more people we'd be seeing having decreased sleep. So that certain cardiovascular problems, as we see here, would increase, such as total cardiovascular disease, but specifically chronic heart disease, heart failure, stroke, and atrial fibrillation. As we look to the left, the diagram on the left, it's really interesting that high cholesterol is portended to decrease by 2050, and that's probably because of the health behaviors that we're going to see more and more of. This slide just here to remind us that as the dose of sodium increases, this is also associated with increasing cardiovascular events. And this is both in Blacks as well as whites. As we think of salt or high salt in cardiovascular disease, there are several mechanisms, and several things that we have noticed is that high salt can, of course, result in hypertension, but it's because it can affect so many different things, even from at the vessel level, causing damage to the vessel, inflammatory and immune responses, genetic responses, gut biome responses, and just overall sensitivity. Let's look a little closer at each of these. So high salt consumption, we know, can cause increased fluid retention due to the osmotic properties of salt, and it can lead to elevated arterial pressure, elevated cardiac output. High salt can also be associated with left ventricular hypertrophy, where the muscle in the heart itself thickens, and this can often lead to congestive heart failure. On the other hand, high salt intake can cause endothelial dysfunction, impairment at the level of the blood vessel, causing atherosclerosis to develop and later heart attacks. Elevated salt levels can also increase inflammatory responses leading to atherosclerosis, and that can also lead to cardiovascular diseases. There are some pro-inflammatory things that can increase with high salt, as well as prostanoids that are produced with elevated salt levels. These all contribute to abnormal platelet function at the level of the cells, as well as inflammation leading to increased atherosclerosis and even myocardial infarction. There can also be genetic predisposition in terms of responses to salt. We know that there are certain variants that can lead to salt sensitivity, and we can see this in African Americans. High salt intake can also lead to methylation of certain histones or affecting genes, causing inflammation, endothelial dysfunction, and again leading to increasing overall cardiovascular risk factors. Gut biomes are not excluded at all, because dietary salt can also lead to imbalances in the microbial community in the intestines. And so these changes in the gut microbiome can contribute to endothelial dysfunction, again leading to atherosclerosis and other cardiovascular conditions. Now, as we turn our attention now to the treatment of narcolepsy in terms of as the treatment relates to cardiovascular risk. So we've already seen that narcolepsy by itself brings with it certain cardiovascular risk. Now, when we add to this now the treatment, it's important to recognize the array of agents that we have available to us to treat narcolepsy are not without significant cardiovascular risk. The amphetamines that can increase levels of norepinephrine and epinephrine can lead to elevation in heart rate and blood pressure, leading to arrhythmias. And then we have some like modafinil that can cause hypertension, angina, and even myocardial infarction. The oxybates with high sodium load, they can lead to hypertension. And of course, now there are oxybates with a lower sodium load that are more favorable. Pitolisant that can lead to QT prolongation, resulting in, which can lead to abnormal cardiac arrhythmias, and solriamfetol that can increase heart rate and blood pressure. If we look closer at the ASM parameters for idiopathic hypersomnia, we see that modafinil has been recommended strongly, whereas the others have conditional recommendation. Low sodium oxybate is only FDA approved in the treatment of idiopathic hypersomnia in adults that are over 18 years old. Let's look a little closer at the sodium oxybate as well as the low sodium oxybate as used in addressing excessive daytime sleepiness and cataplexy. Usually, it's the first-line drug for the treatment of narcolepsy and the most effective drug in the treatment of cataplexy. It helps with the sleepiness that is associated with these conditions, and the dosing can be up to 1 to 3 times a night. The side effects side effects that can be associated with these drugs, and these side effects can be minimized by changing the dosing or by reducing the initial dose of the medication. If we look at pitolisant addressing excessive daytime sleepiness and cataplexy, this is a histamine receptor agonist that is selective for the H3 subtype. And this is effective in both excessive daytime sleepiness and cataplexy in adults and children over the age of 6 years old. Again, we can see there are different doses here, but it's important to note for pitolisant that adjustments need to be made for liver and kidney impairment or those that are poor metabolizers of the CYP2D6 part of the cytochrome P450 system. So it's often contraindicated in patients with severe hepatic impairment and those with can increase the QT interval, again leading to arrhythmias. There often is reduced efficacy in those on oral contraceptives because it increases the metabolism of the ethinyl estradiol. And so it's important to remember that as we dose this for patients. If we look now at modafinil and armodafinil, which is used a lot for patients with excessive daytime sleepiness, although they're both effective for daytime sleepiness because they're mainly dopaminergic, there's no effect on cataplexy. So patients that have narcolepsy type 1, there's no indication. Again, there's reduced efficacy for patients on oral contraceptives, and it's not without its own severe complications. It can cause rashes and even allergic reactions. The doses for modafinil is anywhere from 100 to 200, and sometimes they even need twice a day dosing. The armodafinil has a longer half-life, up to 15 hours, and so this can often be given as a single dose once a day or once a day dosing on this medication. Solriamfetol, on the other hand, again used for excessive daytime sleepiness, which is a dopamine norepinephrine receptor inhibitor available in different doses. And this can increase blood pressure and heart rate. It has no effect on the prolongation of the QT interval, but because it can increase blood pressure and heart rate, can often increase anxiety, insomnia, and irritability. So these has to be taken into consideration. There's no effect on cataplexy for this drug. When we look at amphetamine and methylphenidate, again, these have been used for stimulants for patients with narcolepsy and idiopathic hypersomnia. In one study where they compared to control patients, they found that especially those that were on maximum doses, there were increased risk of a lot of psychosis and other causes, neurological causes in patients taking these high doses, like psychosis, a lot of psychiatric hospitalization, tachyarrhythmias, and polysubstance abuse. In patients with high dose of the amphetamine methylphenidate, we have to be careful about these side effects. This is just to remind us that sleep is now one of the American Heart Association essential 8 factors, along with all the others that we know: cholesterol, lipids, the importance of exercising, being active, not smoking, exercising, and eating well. So poor habitual sleep is an increased risk factor for other cardiovascular problems. So it's important to emphasize the importance of sleep in minimizing the comorbidity and morbidity of heart disease. Now, this slide just appears to remind us that in switching from the high dose to the low-dose sodium oxybate in patients in the XYLO study, we were able to see a significant improvement in daytime ambulatory systolic blood pressure, as well as mean 24-hour systolic blood pressure changes. Those were very significant in switching from high to low sodium oxybate. Hopefully, we have gathered from our conversation today that in managing patients with narcolepsy and idiopathic hypersomnia, it requires an individualized approach. That's number one. It also requires a whole care team approach, because we first have to recognize the innate risk in narcolepsy for cardiovascular disease. That's number one. So it means that as we begin to evaluate patients for treatment, it's important to recognize their lifestyle. Are they smokers? Do they use caffeine? Do they use cannabis? Any other risk of misuse that the patient may have? Looking at drug-to-drug interaction, dosing regimen, can they tolerate the medication, and concurrent conditions that they may have. So it has to be individualized to the patients. So we need to monitor all these cardiovascular effects: blood pressure, weight, their BMI or waist circumferences, and also to assess for obstructive sleep apnea, because obstructive sleep apnea by itself can also be a risk factor. There's also guidelines in terms of monitoring their cholesterol and hemoglobin A1C. In patients with high blood pressure who have a family history of cardiovascular disease, importance of measuring the diabetes, the blood glucose, and all the metabolic syndromes as we think about managing these patients. So it's important to monitor their cardiovascular risk very closely, as we are also treating their narcolepsy and idiopathic hypersomnia. And this could be done through notes that could be sent to their primary care physicians to make them aware, so that they know to monitor these things, because it's a whole team approach to managing these patients. So in conclusion, let's remember that narcolepsy is linked to a higher cardiovascular event risk in terms of stroke, myocardial infarction, arrest, and revascularization. And it's important to screen these patients proactively for all these cardiovascular risk factors as we begin treatment. Even as they've been treated, frequent monitoring of their cardiometabolic comorbidities such as hypertension, obesity, dyslipidemia, and glucose intolerance through measuring their lipids, A1C, blood pressure is all very important. And remember some of the risk associated with some of the current treatment. The stimulants and solriamfetol can raise heart rate, blood pressure. Pitolisant can prolong QT interval, resulting in arrhythmias. And high-dose sodium oxybate can increase the sodium load. So it's important to choose the low sodium oxybate to avoid in patients with severe or advanced cardiovascular profile. It's important to emphasize prevention and individualized care. Lifestyle changes such as weight management, smoking cessation, salt reduction, and treatment of obstructive sleep apnea is just as important. And it's important as we treat these patients to document their baseline cardiovascular status even before starting the agents, whichever selection you choose, and then reevaluate these cardiovascular baseline parameters as they are being treated on a regular basis. Thank you, and I would entertain any questions at this time, and I thank you for your attention. So I see a few questions in the chat, and I will attack a few of them. One question I see: how do cardiovascular risk influence your medication approach in older insomnia, especially those with multiple comorbidities. In selecting the management of these patients, first of all, we have to balance the benefits and the risk. And so using one with the least side effects, sometimes starting if it's narcolepsy that they have, and I'm trying, if you want to try the oxybate, using a low sodium oxybate option and monitoring their blood pressure at the beginning before starting and throughout management, making sure that other things such as their cholesterol, their blood glucose levels, those are all managed as you're managing these patients. So keeping an eye on everything, I would say, is important, especially on older adults, because they can easily develop even congestive heart failure if their blood pressure gets too elevated. If they're on stimulants, they can develop anxiety, so that's important. What is the cardiovascular significance of comorbid sleep disorder breathing in patients with narcolepsy or idiopathic hypersomnia? And how does this influence diagnostic and treatment pathways? So in patients that have sleep disordered breathing, we now know that sleep disordered breathing, which left untreated, can lead to several things. It can lead to uncontrolled hypertension, elevated blood glucose levels. It can lead to abnormal heart rhythm, atrial fibrillation. It can lead to elevated blood glucose levels. So if someone has sleep disordered breathing, I think it's important to treat that first before beginning the additional treatment for narcolepsy and idiopathic hypersomnia, because you want to minimize those comorbidities as you manage these patients. I'm just picking some because of time here. I see one that, which cardiovascular risk factors should clinician prioritize screening for in patients with central disorders of hypersomnia? And are there patient groups who warrant earlier and more intensive cardiovascular evaluation? So if I say, as you said, which cardiovascular risk factor, the big one that I would say is high blood pressure, because sometimes that's the one that's easily measurable in any offices across any, whether it's a specialty or primary care, starting with the blood pressure, because you want to know what's your baseline, where you're starting from, because especially when you think about stimulants, if you wanted to add stimulants, can further increase blood pressure and heart rate. And the last thing you would want is starting someone on a stimulant that the blood pressure was not evaluated at the beginning, and they end up with a TIA or stroke or some comorbid concomitant disorder that could be detrimental to them. So I always say, at least start with the minimum, knowing what their blood pressure is. If you have access to other labs, to their lab panels, let's say, you want to know if they also have a propensity for diabetes, prediabetes, or high cholesterol. So that's what I would suggest on that one. I hope that you are able to leave with some pearls that you can apply to your specific field, whether you're in specialty or in primary care, that can help as we manage patients with narcolepsy and idiopathic hypersomnia. And again, I want to thank you today for your attention, and see you next time around.